Okay. There we go.
Okay. All right. Well, this is our first time going live on YouTube.
That's pretty exciting.
It is kind of exciting. So we're hoping for a little bit smoother, more timely broadcast in the future. We were having some issues with Facebook Lives, and really that works okay. But this so far has been simpler. We'll see if this works out. Still, of course, this will be accessible on all the podcast platforms out there.
Definitely.
So you can always check out the audio version. That's most of what you want to know about anyway. Of course, then you get to miss our beautiful faces if you're doing audio only. So,
and audio version will be available Monday.
That's true. Yep, it will. It will. Absolutely. So thanks for joining us if you're here. My name is Dr. Jason Roundtree. I'm the founder of Laser Therapy Institute. I'm a chiropractor and a certified medical laser safety officer. And I'm joined today by Christy, who is a certified laser tech. She's done a billion treatments over the years, but she's also heading up our online course development. And so if you are a doc who is looking for courses, we've got what you need. 90+% of our program can be done online on your own time with our individual personal support. So if you are wanting to know more about how to use lasers successfully, which is the topic we're going to talk about today, if you want to know more about using lasers successfully in your practice, get a hold of us. We'll connect you with the resources you need. We got a ton of free stuff you can get too.
I was going to say, there's a lot of information just available on our website.
Absolutely. Yeah, so check out the website, lasertherapyinstitute.org. Get a hold of us. Let us know what kind of needs you have. We can fulfill whatever they are. Everything from basic safety training and how to set your clinic up all the way up to the advanced custom protocols that we use every day and we see work and that are used in our clinics across the country.
Right.
So, but today's topic is going to be heel spurs.
Nice.
Heel spurs, or more properly, enthesophytes. Calcaneal enthesophytes.
I don't know that I can say that word.
That's okay.
I'd rather say heel spur.
If we just say heel spur, people know what we're talking about. Yeah. So this is where a patient will come in with pain on the bottom of the foot. In many cases, you're going to diagnose plantar fasciitis. If you get an X-ray, you may know presence of a heel spur. How much does that matter? What do you need to know about it? Is it something that can be lasered? That's exactly what this study looked at. Does laser help patients with painful heel spurs? So we'll break that down for you. Before I go any further, I do want to put out a plug for our patient-focused podcast. So this LTI podcast is our physician-focused podcast. Our healthcare provider really is the focus here so that we can try and communicate what the research says in a way that you can employ that to help your patients with laser therapy. And if you're a patient listening in, continue to listen in. We're just might be a little more focused on the physician side of things. But you can check out our other podcast, Healing at the Speed of Light, where we go through a lot of the same research, but in a way that is a little more understandable for the average person who doesn't want to learn all this crap, all these terms, and also a little bit more something you can leverage in your day-to-day life and help you get good care for whatever it is that is ailing you. So,
both very beneficial.
Yeah. Yeah.
So.
Yeah, both are good. And if you're a physician listening to the podcast too, check out the patient focused podcast because there's over 100 episodes there. If you want to send a patient information about a particular disorder, you can just share that particular episode with them, and then your patient education is basically done for that one.
There you go.
Yeah. Okay, so anyway, check those out, but let's go ahead and talk through this study. Now, this study was published in 2020 in Lasers in Medical Science. It's actually published online at the end of 2019, but it's in the 2020 version of Lasers in Medical Science, and the title is The Effect of High-Intensity Laser Therapy in the Management of Painful Calcaneal Spur, a double-blind, placebo-controlled study. So, pretty high-quality study overall. An interesting topic because we've seen a good number of studies on plantar fasciitis and foot pain. This is one of the few with an actual painful calcaneal spur. I will say, not every heel spur is painful. There's a lot of people walking around out there right now with heel spurs that are not painful.
So there's a difference, obviously, between heel spur and plantar fasciitis.
Yes, although there is a connection, we think. So actually, let's go to the study because they talk about this. Recurrent microtraumas and chronic damage in the small foot muscles and plantar aponeurosis insertions caused by recurrent injuries are known to play an important role in the pathogenesis of heel spurs. So in the connection points of those foot muscles on the bottom of the foot, and also the connection point of the plantar fascia, right? If there's these recurrent traumas or strains and inflammatory processes, then the body can only react a handful of different ways. One thing that sometimes happens is the plantar fascia actually gets thickened up. It almost goes like a tendinosis type process where that connective tissue gets larger as the body tries to reinforce it, but it's very disorganized. The fibers aren't all laying next to each other, being very strong, good elasticity. It's just kind of jumbled in there. There's fibrosis, scarring, all that junk that makes that look thicker. You can see that on ultrasound.
What causes this? I mean, I'm coming from a perspective, I know you're talking to clinicians and providers, but what causes bone spurs or heel spurs and plantar fasciitis?
Well, the plantar fasciitis is probably the biggest one we should focus on there because that's what you usually feel before you get a symptomatic heel spur. And there's a lot of different causes. One can be overtraining. One can be failure to properly mobilize the foot. And the biggest one, though, is improper footwear. And I think we're all guilty of wearing crummy footwear at some point.
Well, we don't want to replace it. It's expensive.
It is, yes. You wear the broken down stuff. You throw on the flip-flops to, run over and see the neighbor or whatever. I mean, there's a lot that we do to our feet that can overwork them, and that's what really starts that chronic inflammatory process, and that's what produces the pain. Pain is accompanied, though, by tissue changes like this thickening process. Okay. Right, so you can see that at some points it will damage the plantar fascia enough that it can't thicken. It actually gets thinner and more fragile.
Okay.
So we have to watch for that as well. Again, something you can see on ultrasound. Some people, the body will actually start to calcify the connection point because that's its way to reinforce it. Kind of like a tendinosis process. It's actually, there's a term called calcific tendinosis. Which happens like in the shoulder and other places there. And this is kind of a similar process. It's under chronic repetitive strain, microtraumas, like they say in the study. So the body starts to add calcium to this connection point where the plantar fascia attaches to the heel. Okay. Now, on x-ray, you can see this really obviously. The bottom of the heel, you'll see this big chunk of bone sticking forward on the foot, and it looks like just a completely foreign object has grown out of the heel. It's really not. Right. It's actually a calcification of an existing attachment, right? But it's a giant chunk of bone. How much does that really matter? Well, they say in here that the heel spur is found to cause heel pain between 30 to 89% of cases. That's just a really wide range, but that's to say, there's at least 10% of cases out there that are not a problem. At least 10% of heel spurs are not a problem. Maybe as much as 70% of heel spurs are really not a problem. So if you happen to shoot an x-ray on a patient and they have a heel spur, you really probably don't have to go, oh my gosh, we've got to fix everything about your foot if they don't have any foot pain complaints. Don't go hunting for a problem when there really isn't one. However, if they have these plantar fasciitis-like complaints, pain the first step in the morning, pain after resting, pain when they go to get up from sitting in a chair for a few minutes, that goes away the more they walk, that might be tied in with a heel spur. Certainly could.
So if there's someone who's walking around with a heel spur, does it just go away eventually, or will it eventually cause pain?
We don't know.
Okay.
We don't know. And I can say just from clinical experience, I've seen people that come in, have a relatively recent onset of plantar fasciitis, foot pain on the heel, something like that. And maybe it's just been the last couple of months. We get an x-ray, or somebody else has already done an x-ray. We look at that, and there's a huge heel spur. Well, that did not start 2 months ago. That's been going on for a while. So I know in some cases it can go on for a while and then become painful. In other cases, it never becomes painful. So where's the value in even caring then, right? Why do we even care if there is a heel spur that's painful or not? Well, because it changes the way you approach the injury. As a clinician, you cannot really treat a plantar fasciitis case the same if you have heel spur. You should at least be aware of it so that because it really could be affecting your treatment plan and the schedule, even the options you offer the patient. So it's good to know about.
Yeah.
There's a couple other things here I thought I would go ahead and bring out from the study. The symptoms include inflammation, swelling of the feet, and pain when weight is given on the feet. Also limited range of motion. There's no standard treatment for calcaneal spur. Generally, conservative treatment includes things like NSAIDs, steroid injections, cortisone injections, stretching exercises, acupuncture, ESWT or shockwave therapy, and laser therapy, arch supports, heel pads, and night splints. So there's a lot of different things that can be thrown at this, and that's why you've probably heard 80 different strategies to address plantar fasciitis, and that's why patients say, oh, nothing fixed my plantar fasciitis until I did whatever. There's a whole bunch of different things that can be done, but there's really no standard.
Okay.
So don't have anything that's a go-to. They do go on to say that high-intensity laser therapy does have benefits for anti-inflammatory, anti-edema, and analgesic mechanisms. Compared to other laser sources, high-intensity laser offers the advantages of high penetration into tissue and the ability to treat deep tissues and structures through its operation at the right wavelength. And the right wavelength in this case they're saying is 1064 nanometers. That's on the little bit closer to the kind of mid-infrared spectrum. Invisible, right? So now most people, if they've heard about lasers and they know anything about low intensity versus high intensity lasers, they know that there's some level of warmth that can be generated in some cases by high intensity lasers. And low intensity lasers really do not generate any heat in their application. They say that this photothermic effect, or this warming effect, is kept under control in terms of safety and comfort by just adjusting the intensity and the frequency at which it's being applied. The technique as well is important. With a low-intensity laser, you're typically going to apply it and hold it to the point that you want to treat. With a high-intensity laser, you're going to scan over the area that you want to treat, and that helps to mitigate some of that warming. Nothing wrong with a little bit of tissue warming, right? Everybody loves a heat pack.
Right.
But that's not the goal. That's not the mechanism here. That's not the goal. So
the goal.
we want to manage the heat so it stays comfortable, and that scanning motion is how you do that while still delivering a large, in often cases, a large dose of light to those tissues.
Well, and it gets the surrounding tissues too. I mean, you're getting a wider area.
You're exactly right. And that's another point we should make, is that if you're going to apply laser to a painful calcaneal spur, you should be treating the entire plantar fascia. Not just the spot that you think has the spur. Not only might you be a little bit off, unless you're like doing a guided procedure with ultrasound, but you need to get those surrounding tissues. I mean, the plantar fascia is extremely dependent on the surrounding tissues being healthy as well to bring in fresh circulation and exchange lymphatic fluids. So you should be treating the entire heel and the whole bottom of the foot. Some people will treat even more. They'll treat the leg, the ankle, the bottom of the foot, the heel, sometimes the top of the foot. My point is, though, and the point that you bring up is, we don't want to treat just one tiny spot. We really want to address all the tissues that could be part of this equation.
Right.
Yeah.
Right.
Yeah, it's a very good point. Thank you. The other thing is you want to pick the right kind of patient. And what I mean for that is you want to pick a patient that's going to be successful with your care plan. So in order to do that, you need somebody who will follow what you say, recommendation-wise. Now, in this case, they took these subjects and asked them not to take any analgesics or NSAIDs. They wanted to eliminate any of those anti-inflammatory factors. We do know that in a lot of cases, anti-inflammatories will limit the benefits that laser can have. They also took people that had heel pain on palpation and had a diagnosis of calcaneal spur, which was seen on a lateral x-ray of the foot. Let's see what else. That was the main thing there. So it's a pretty low bar. But just if you've got somebody who's not going to stop taking their ibuprofen, they're going to have less success rate when it comes to this kind of thing.
Right.
So.
Right.
So, like I said at the top, it's a double-blind, placebo-controlled study. which means that we've got an actual sham laser treatment going on, and the therapist didn't know which one they were doing, the live treatment or the sham treatment. The patient didn't know either, that's what we want to go for. That's kind of our standard that we want to see.
Because sometimes if you know, your mind does help control some end result.
Absolutely. Yes. Which can be just fine in clinical practice, but not in a study.
But not in a study.
Yeah, we want to see what works and what doesn't.
Exactly.
So the first group of participants here, they had the high-intensity laser plus exercises. Second group had the placebo laser therapy along with the same exercises. The exercises were done 5 days a week for 3 weeks, about 25 minutes worth, and they're very, very standard, very typical stretching and exercises, range of motion exercises, some strengthening of the tibialis posterior and pronatus longus. Really exactly what you've probably done in clinic, what you've seen done by PTs, the whole bit. So very normal, very standard, and I will say helpful. So we'll come back to that in a minute. The patients who got laser were getting a laser that's actually not available. It's an Italian laser that's not available in the U.S. at this point. Very, very high peak power, 3,000 watt peak power, but a much lower average power, 10.5 watt average power. Okay. So putting out large bursts of light, but just very briefly. So the average power's just over 10 watts. They delivered 1,281 joules during each session, which took about 10 minutes with that particular laser. Okay. Many other lasers are out there that can do that a lot quicker. Actually, the same dosage, but can deliver it to a larger spot size in a much quicker amount of time.
So did they do the whole bottom surface of the foot?
As far as I can tell, they did the whole heel, and it sounds like most of the bottom of the foot. Okay. Yes. Okay. Because in calculating it out, it appears that they did about 8 joules per centimeter squared. Okay. So it covered a lot of the foot, I believe. Yeah. I could be wrong. If you were on the research team for this one, let me know.
Yeah.
They did laser therapy at the same rate too. So they did laser and the placebo laser 5 days a week for 3 weeks, total of 15 sessions, and they just disabled the sham device. It was same device, just placebo settings, and actually a lot of lasers have that to enable you to do studies like this, so that you have a good placebo control. They really did a good job investigating the outcomes on this one. So they measured heel pain severity in the morning on a 0 to 10 scale, general pain level assessment, which was a questionnaire, a health-related quality of life assessment, which was, again, a questionnaire, a function assessment, foot and ankle outcome score. They also did a plantar pressure measurement using a pedograph, and they did a dynamic measurement with this by putting the patient on a walking platform, had them walk, and they actually took, they kept track of the pressure on both feet, the posture of the patient, symmetry and parallelism of the shoulders and the feet, contact area of the heel on the medial and the lateral side. And there's quite a bit that went into that. Pretty extensive. Yes. Yeah. Because pain is your kind of primary outcome here, but they wanted to see function-wise if this would make a difference as well.
Well, when you get back to, some of the causes, improper footwear. If you're looking at that, simple posture and contact level. I can see where it's all beneficial.
Yeah. Yeah. If you've got crummy footwear and it's not letting the foot move like it's supposed to, it's just this repetitive strain, really. So they did this for 3 weeks, 5 days a week for 3 weeks, and what they came away with when they did the final measurements. They retook these tests at 4 weeks after they started and 12 weeks. So 3 weeks of laser, then a week after that they did the measurements, and then 12 weeks later they did the measurements again. They said there was no significant difference in the pre-treatment and post-treatment values for pain.
That's very interesting.
Most quality of life and function scores at the 4 weeks and 12 weeks were about the same too, but there was a significant difference in the dynamic pedobarographic values in favor of the laser therapy group. Now, they go on to talk about actually they had some pretty good results in pain for both groups, but they were so identical that they really didn't say that one group could win more than the other. So the advantage here for laser in this study was only for the way that the patient was walking. So
Interesting.
they functioned much better, but their pain levels were about the same. So you'd think that's weird because laser is supposed to help with pain. Why did it not help with pain?
Right.
Or why did it help just as much as the placebo laser did? Is it all placebo? Well, clearly not. These folks were, is a statistically significant change in their walking biomechanics. So something changed with laser that didn't. But what was it, and why didn't we see better pain relief results? That's what I want to know, at least when I read this.
Yeah, it's a curious thing.
Yes. Yes, it is.
But you're going to tell us, right?
I'm gonna tell you my guesses, because I don't have a study that did things the way that I would have done it necessarily with this, but we do have another study, same type of laser, actually a little bit different device, but same wavelength, high intensity, class 4, 1064 nanometer laser. That was done on plantar fasciitis cases without heel spurs, so usually less severe or less tissue change, I should say. They treated them 3 times a week for 3 weeks, and they had very good results. So that right there tells me there may be issues with the schedule that was picked in this case.
Okay.
5 days a week is a lot, and it's really, in my opinion, almost never necessary when it comes to some of the high intensity devices that we have. You can put so much energy into the foot, you really just don't have to do it every day. Also, they crammed it into 3 weeks. I think they just kind of overworked the tissues. Even the exercises may have been a little bit too much at 5 days a week.
Yeah, but that's a good point.
That's a
very
lot.
Good point.
And if you go and you lift bicep curls 5 days a week for 3 weeks, I mean, how far are you really going to get?
Right.
Is it really worth it? Probably not.
Well, when you think about that, your muscle fibers are breaking down. And they need time to heal. They
Right.
need time to regenerate and get stronger.
They do. You
And
need that
I think
break.
it's the same thing with this.
Yeah, I would guess so as well. And not that they hurt anybody. They did help all these patients through rehab. And so that's my number one takeaway, that rehab really is critical, because that's why these patients in this study felt better, is because of the rehab, not because of the laser.
Okay.
So do your rehab. And you can't just ignore the rehab side of things. And it does go well with laser. So if you're doing laser therapy, go ahead and do your rehab too. The other takeaway that I would leave you with is that longer and less intense scheduling is usually going to be better, especially in the case of chronic tissue changes and adaptations like heel spurs or tendinosis. You've got to give the body time to make those changes in terms of reversing some of the damage and the inflammation, because those tissues are not normal anymore. Right. So if you have something that you know is more chronic, either you've got shoulder tendinosis, rotator cuff tendinosis you can see on your MRI or ultrasound, or you've got a heel spur you can see on your X-ray. Those are more intensive tissue problems than somebody with simple tendinitis or plantar fasciitis without a heel spur. So give them the time. That's the biggest thing. Give them time to see that change, and don't worry about doing it every day. I just don't think that's going to be our best schedule, especially we've got this other study on plantar fasciitis 3 times a week, 3 weeks, and they actually had very good results. I think you can, in most cases, get away with a 3 times a week kind of schedule for patients even with chronic problems. Now, more acute, maybe acute whiplash, I can see treating that every day. But something like this, I don't think it's worth it. The patient's not going to get their bang for the buck, and you may actually even be overstraining the tissues and slowing down the patient's progress, especially if you're working them hard in rehab and you're throwing laser at them all day. Every day. So let's look at what a successful laser protocol probably looks like. Number one, you do need to make sure they're in proper footwear. Because if you are fighting bad footwear, it's going to be an unending battle. You will help the patient only as long as they don't wear those crummy shoes. So check out their gait, see what they're wearing, make sure they've got good shoes on. That's number one step. Number 2 step is put them in a night brace. The nighttime braces hold the foot in a way that don't allow as much inflammation to gather in the fascia, we think. They're also cheap.
Really?
Yep.
Okay. And how long would they wear the night brace?
Until they're feeling pretty darn good.
Okay.
You only wear it at night, and it's a
Right.
little awkward to sleep with that first night or two, but it makes that first morning step a heck of a lot less painful for most people. Now, some people, you'll prescribe these, they'll use them, and they won't notice any difference in like a week. If they're not seeing a difference, fine, they can discontinue. But most patients are going to be better and get better quicker if you put them in a nighttime brace.
Interesting. Hadn't heard that before.
That's a good one
That's
for
a good
anything plantar fasciitis, especially if it's got heel spur there too.
Okay.
And then I would say 6 to 10 weeks of laser, depending on the severity of the patient's case, how chronic the problem is. 3 weeks is not enough. 6 weeks is probably about enough, but certainly going all the way out to 10 weeks is not unreasonable. It's taken years for that spur to develop. This is not going to be a problem that goes away in a handful of days. It just isn't. In most cases, the pain will be the first thing to go away, and not even the tissue damage. So carry this thing through so they're not right back in your office a month later saying, oh, well, it came back.
Well, that's a good point. Pain goes away. They say, okay, I'm healed. It's not a problem anymore. But you still need to continue the treatments to have a more long-term effect.
Yes. One of the mistakes that I made very early on in my laser therapy journey was we would get people out of pain pretty quick in a lot of cases, and then I just send them out the door. And I had a lot of those people that came back and, a month or 3 months later and said, hey, I was really good. And then it came back. Nothing really happened, but now the pain's back. It's the same as it was before. It's really frustrating. So what we learned is that by tapering them out of care, you can deliver just a few more sessions and have them stay good for a much longer period of time, much more happy with their results. And it also lets you kind of keep track of that patient. Do they go back to wearing those flip-flops, and have a flare-up? So it helps you head off some of the episodes that they might, go into. So it's not about getting more visits on the schedule, right? It's about getting the patient better so that they stay better.
Right.
And this is the best way to do that. Because the happier the patient is, more likely they are to bring in their friends and family and come see you whenever they have anything that they need fixed.
And then there's still that on the patient. They have to choose the right footwear. They have to
They do.
make some different choices.
Yes.
Yeah.
And make sometimes some lifestyle choices,
Right.
Yeah.
Yeah.
Last thing for a successful laser protocol, so you got proper footwear, use of a nighttime brace for most cases, 6 to 10 weeks worth of laser therapy. Adding in shockwave therapy appears to be quite good as well, not only for heel spurs, but for plantar fasciitis in general. So I would say that is not a bad thing to include in your laser care plan because you can do them both. They actually support each other just fine.
Okay.
If you're not getting any response in that 6 to 10 week range, if they're literally just not getting better, that's when we'd probably consider looking at some type of regenerative injection like PRP. But please don't let your patients go get cortisone injections in the foot. It's damaging. It thins the fascia. Rupture of the fascia is a real side effect of cortisone injections into the foot. So if there is any way to get your patients to avoid those, I highly recommend that. I talked to a patient today who had that done. Said it was the most painful injection they had ever had. They couldn't even imagine how painful it was. And she's telling us this as we have her on the table doing about 10 PRP injections into her knees.
Wow.
But that foot injection of cortisone specifically was the worst thing. She had a PRP injection that actually fixed her plantar fasciitis later.
Cortisone is just so temporary.
In a lot of cases,
In a
yeah.
lot of
Some people do
cases.
get some lasting relief from it, but in a lot of cases, you are sometimes even setting yourself up for failure later. And that's not a good place to be.
Just the word damaging, that keeps me from wanting to go there.
And that's why we like laser.
Yes,
Laser
exactly.
is non-damaging.
Non-invasive.
Non-invasive. PRP is non-damaging, but it is an invasive process. Can be useful in some cases, but start them with the non-invasive.
Right.
It's the safest. It's the easiest for everybody. It's completely comfortable when it comes to laser. Shockwave can sometimes be a little bit uncomfortable, but it's not bad. Using a nighttime brace. I mean, these are all things that really do work, that have been shown to work well. And put them together, get your patient better, help them avoid the cortisone injection, help them avoid future surgeries,
Right.
even if they have a heel spur.
Right. Exciting. Interesting. Very interesting study, and hopefully long-term success for people if this becomes their issue.
Right. That's the idea.
But they have to find a place to go.
That's right. if you're a patient listening to this going, well, sounds like I want to do some laser therapy, get with a good clinic that does it. Go to our website, lasertherapyinstitute.org. Click on the clinics tab. It'll take you to a map of all the different clinics we have across the country, as well as some non-affiliated clinics that do offer laser therapy. Talk to your doc, your chiropractor, your PT, see if they offer laser therapy, see how confident they are. Do they know how to treat plantar fasciitis? Because if they do, awesome. If they don't, they can talk to us also. You can find out lots more at the website.
But providers who are watching.
If you're a provider watching, add yourself to our map.
Exactly.
It's free to add yourself to the map. If you want to know more about how to do this kind of thing, that's where you need to go ahead and talk to us about what your needs are so that we can meet them. We can give you we could set you up to do nothing but laser therapy all day, every day, with all the different types of conditions that laser can be used for. Or you can be very narrow. You want to learn how to do neuropathy treatments? We've got you. We got you covered. We've got a package just for that. You can learn about it and be up and rolling tomorrow with neuropathy patients getting better in your clinic. So let us know how we can help.
Yep.
See you next week.